This presentation is about the Return to Learn After Concussion policy of North Carolina. There is an annual estimate of about 1.1 to 1.9 million cases of diagnosed concussions due to sports or recreational activities with students. About 20% of those affected are middle and high school students, and 50% of that annual estimate occur from sports. It's important to note that playing a sport increases the likelihood of attaining a concussion threefold. Additionally, about 40% of youth athletes with concussions return to their sports prematurely. These figures all play an important role in the nationwide advocacy for protecting school children from concussions. The national media played a huge role in the beginnings of the fight for concussion advocacy. The national coverage of the devastating physical disabilities that a high schooler named Zachary Lysted attained in a football game because of returning to a game regardless of showing concussion symptoms was the spark that started the national conversation. This passion for better concussion care nationally eventually led to the Zachary Lysted Law of 2009 in Washington state. Part of its success was not only the national coverage of the media, but also the support of the National Football League, which helped further push all states to create its own concussion legislation. The Center for Disease Control and Prevention answered this call and created an evidence-based return-to-play protocol, which details the steps that need to be taken prior to a student-athlete being cleared to play again. North Carolina eventually passed its own concussion legislation in 2011, called the Gefeller-Waller Concussion Awareness Act. It covered middle school through high school students and had 4 components: education, identification and management of concussions, creation of a site-specific emergency action plan in the instance that a concussion does occur, and have records that show compliance. This is the first step in North Carolina's concussion advocacy. After several years of continued advocacy and concussion care improvements, North Carolina responded with a Return to Learn After Concussion policy. It is estimated that 90% of students with a concussion report at least one concussion symptom when they return to school. This is not only a terrible hindrance for the student's education, but it is also not ideal for healing concussions. The accepted evidence-based recommendation to promote brain healing after a concussion is rest and slow progression of activities that do not cause symptoms to flare up. The North Carolina State Board of Education created the Return to Learn After Concussion policy in response to this problem and to further expand the actions that the Gefeller-Waller Act started. This policy covers preschool through 12th grade high schoolers and applies to all students that have a concussion regardless of how it happened. The Return to Learn After Concussion policy has 4 major sections, in which the first one has 4 subsections. First is that schools throughout North Carolina have to make a plan to implement concussion management within their school. These plans require the following: removal of the student from physical or mental activity if a concussion is suspected, a procedure to notify all involved education staff of the student's removal from learn or play, medical care expectations from the student's parents and how the school will provide accommodations for that student with a concussion, and what requirements must the student meet for clearance from return to play or return to learn. The second part of the policy dictates that a concussion team must be identified by the school to supervise the child through the return to learn process. The policy provides a list of people that could be part of the process, but leaves the decision up to the schools of who ultimately is part of the team. Thirdly, the school must provide annual concussion education focused on return-to-learn issues for all school personnel, including coaches. And lastly, The inclusion of a question regarding any past head injuries is to be included in the annual health history and emergency medical information form that the school provides the students. Multiple people affected by the Return to Learn policy. The families of the students with concussions will be constantly exposed to the adjustments that concussions require. They are the direct caregivers of the student and will be the ones reporting about all the medical updates to the school's concussion care team. The educators are also affected, for they will be the people helping the student adjust to their current physical ailment while they are in school. These teachers have to be aware of the nuances of concussions to appropriately adjust or progress the material they are demanding the student to digest cognitively. On a larger scale, school districts are affected by the policy as well. Each district will have varying budgets and resources, which can create variations in the manner that the Return to Learn policy is carried out. More variation can occur with concussion care management between schools due to the open interpretation that the Return to Learn policy's language has. Primary care providers will be affected by the policy due to their natural involvement in the child's concussion recovery plan. And lastly, school nurses will be a continuous presence in the child's concussion recovery. The policy requires a concussion team to be assembled for each school, and these nurses can help carry out the concussion health plan that the primary provider has given. Essentially, schools will be hard-pressed not to include the school nurse in the Return to Learn team if they are staffed in the school, since these healthcare workers are also a natural fit in the Return to Learn management team. The policy contains both traits that are good and some aspects that could be improved upon. It is an obvious improvement that the North Carolina State Board of Education expanded the population that the policy covers compared to the Gefeller-Waller Act. As I mentioned earlier, this policy now covers all concussions regardless of cause, and the policy applies from preschool to high school students. The goal is simply to help accommodate students that are suffering from concussions to return to their academics as best as possible. Unfortunately, the policy does have room for improvement. The main issue of the policy is that there are no specific Return to Learn guidelines written within the policy. It essentially defers the specificity to each school. This may stem from the larger issue that there is not a nationally accepted Return to Learn protocol, which is drastically different from the Return to Play, which has an outlined stepwise progression of how to return a child to athletic play. The lack of specificity risks having a variety of standards of care if the responsibility is indeed left to the hands of each school. Lastly, because there are no specific guidelines, there is not a clear-cut manner to evaluate the policy. There are several ethical implications associated with Return to Learn and concussion management. The concept of dual loyalty applies to health providers that are caring for student athletes. This occurs as the conflict between the provider's understanding that they are advocating for the autonomy of choice of their patient along with their well-being, which is in stark contrast with the student's priority of being approved to play in a physical sport like football. Veracity applies to all the educators and school personnel who have witnessed a potential for concussion. This is their duty to speak up and initiate pulling the student from risking further traumatic brain injury. Non-maleficence is closely related to the previous ethical concept. It essentially refers to the fact that all education personnel around these children have the ethical responsibility to protect them from harm. Amending the Return to Learn policy should include three concepts. Firstly, the policy should have a written evidence-based protocol that can be applied to all schools. This is an important amendment to include and develop within the policy because it has been shown that positive behavior change and good health outcomes result when policy specifically dictates how care should be carried out. As I mentioned briefly in a previous slide, The problem of not having a clear-cut protocol like the return to play may be due to the fact that there is no nationally accepted protocol for return to learn. Secondly, the policy should specifically identify the school nurse as the return to learn team leader. The key to implementing this proposal is that school nurses have been known to increase the treatment adherence to return to learn protocols. This may be difficult to apply for all school districts because of the varied resources and budgets that may affect each school if a school nurse is present in school or not. Thirdly, the policy should mandate that return to learn clearance should be prioritized first before return to play clearance. This places the ability to learn and progress in academics before athletics. The priority to preserve the cognitive function of a student will be beneficial for the future academic pursuits of the student, as well as their future job prospects. It should be acknowledged that placing return to learn as a priority before return to play may risk isolating the student and increase pressure on them to return to their sport from their peers and their coaches. The steps to amendment can be boiled down to 3 steps. The biggest priority is to educate all stakeholders about the importance of implementing these amendments. All stakeholders should understand all the objective information as to why these proposals need to be included. Secondly is the coordination of all the opinions of all stakeholders in order to focus on an agreed upon goal. Many of these opinions will clash and some will coincide with one another. The policy-making process needs to harness the common traits within all of these opinions and build them toward a common goal of what language will be presented to the North Carolina State Board of Education. Lastly, these proposals will be presented to the North Carolina State Board of Education to be considered. There are some potential barriers that need to be addressed in the proposed amendments. One of the most important is the financial burden that these policy amendments can incur. The threat of having increased healthcare costs for the state should be addressed with the research that found ER visits and CT scans have not increased in states with concussion legislation. Additionally, it should be emphasized that school nurses contribute an astounding net dollar value towards society. It is estimated that for every dollar spent on a school nurse, this translates to about $2.20 net value to society. Overall, school nurses contribute about $98.2 million in net value to society. These numbers need to be emphasized to the State Board of Education in order to appropriately allocate funds to hire school nurses throughout the state. To address the lack of a nationally accepted return-to-learn guideline, the North Carolina return-to-learn policy can be modeled after Illinois' return-to-learn policy. Illinois' return-to-learn policy is the most comprehensive in the United States, for it applies concepts set forth by the CDC regarding concussion management and crafted a stepwise protocol for return to learn. The steps are outlined and can be easily applied in any school within North Carolina. This is a good middle ground until a nationally accepted protocol for return to learn is developed. Evaluating the policy can be accomplished through surveying those involved. Taking a survey of the students with concussions can yield insights into treatment adherence and their perceptions on school accommodations. Potential hindrances to the concussion return-to-learn policy amendments can also be achieved through surveys to students, school nurses, teachers, and parents. It is important to continually evaluate the policies to really understand how best to address the needs of the students in their recovery process. In conclusion, the current return-to-learn policy of North Carolina has both good traits and traits that need to be addressed. The lack of specificity is the primary concerning aspect of the policy that requires immediate attention of all stakeholders. Specific policy interventions have to be included in order to better the care provided to students with concussions and assist their journey with concussion recovery while returning to their studies. This process requires the coordination and buy-in from all stakeholders and has the potential to truly create a difference in the lives of school children throughout the state of North Carolina.